We want to wish everyone a good evening, and we are here at our scheduled video Zoom video conference that the Collective Power of One International have been sponsoring. Throughout the month, we have been highlighting different experts in their field of medicine. So this evening, we have with us Dr. Marg D'Andrea. He is the medical director at the University Cancer Center and the Gulf Coast Cancer Center. And he is an expert in the field of radiology as it relates to cancers, and especially with the prostate. And it is our privilege to have him with us this evening. So Dr. Satya, I will turn it over to you, and then we will get started with our presentation this evening.
Yes, thank you so very much, Dr. Climie, and thanks, Dr. D'Andrea, for joining us today. And I thank all the guests who are joining and those who will be joining us. We're quite privileged to have Dr. D'Andrea with us. He's such a busy, busy gentleman, but yet has obliged to share his knowledge, new techniques, new technologies, in the arena of the prostate cancer. He is quite an expert in this field. Yes, he is the medical director at the University Cancer Center and Gulf Coast Cancer Center. He's on the HCMS Physicians Counseling Committee. He's a principal investigator at the Southeast Research Institute. He's also an affiliate investigator with several other entities, including the Albert Einstein Medical Center in Pennsylvania. He's got numerous hospital affiliations, so he's very, very accessible. He is also a great researcher, and I'm fascinated by the numbers of articles he's presented and written, an author of. So he also likes a lot about environment and what that does and how cancer is actually a result of our environment, whether it is all these oil spills we've had in Texas and so on and so forth. He enjoys doing that, and he's quite the expert at it. So I'm really, really honored to have you, Dr. D'Andrea, today. And I know we will all learn a lot from you, and we will be enlightened, and the floor is all yours. And folks, you are welcome to write questions in the little chat. There's a spot for private questions as well. So, or for everybody else to see. Either way, it's fine. And we will save them for the end, if you don't mind. Thank you. Dr. D'Andrea.
Thank you. Thank you both for the kind introduction. I appreciate my opportunity to be here tonight and share this information. As you know, September was Prostate Awareness Month. So October is Breast Cancer Awareness Month. So we're just right at the cusp of finishing the Prostate Cancer Awareness Month. What's important, why do we talk about prostate cancer? Well, if you look at the number of types of cancers in the world, breast cancer, lung cancer, prostate cancer, head and neck cancer, and colorectal cancer make up the 5 most common cancers that we have in oncology. In the United States, definitely it's breast and lung, and sometimes lung and breast, depending on the year. Now, because of the difference in smoking habits, lung cancer used to be the leading cause of cancer deaths. Now, breast cancer has moved to the forefront. But just like prostate cancer, good things are happening in the treatment of this disease. Tonight, I'm going to outline some basic information, what these statistics are, kind of who gets it, what to look for, what the common treatments are, and at the end, I'll give you some more information about the new types of treatment that are out there, and the great news: this cancer is able to be treated, and you're able to live a long time. So yes. With that, I want to start really with some boring statistics. But in 2020, about 190,000 people were diagnosed with prostate cancer. Of those, about 33,000 will die from that cancer. So basically, about 40% of the men with prostate cancer have a history of prostate cancer. Now, in those who don't have prostate cancer, about 30% have developed prostate cancer. We know prostate cancer happens in men, but about what age? Well, if you have no family history of prostate cancer, starting age 50 and up begins your risk. That's why we ask for prostate screening at age 50. However, if your father or grandfather or your uncle has prostate cancer, we actually recommend age 40, as we do in African American males who have also family history, again, because we can actually pick up this cancer earlier. So in the United States, the highest incidence is among the Black males, with about almost a 10% lifetime risk. White males have an 8% risk, and the Asian population, Japanese and mainland Chinese, have the lowest risk. And we're assuming it's attributed to some type of dietary means. The highest incidence, interesting enough, is in Scandinavian countries, even though you suspect they would eat a lot of fish and things like that, and that may decrease the volume, but actually we find the highest in Scandinavian countries and the lowest in Asian countries. Next slide, please.
Okay.
Next slide.
Let's go. There we go.
Thank you. So what is the risk? First of all, if the risk is if you have some relative that has prostate cancer, you have at least double the risk of getting cancer. And then if you have two people who in your family, like your father and uncle, or father and one of your brothers, you have an even higher risk of having prostate cancer. In some trials, they noted that people higher fat diets may have a higher incidence of prostate cancers. And there has been some studies that show men who had vasectomies had a higher incidence of prostate cancers. That has been shown in several papers, but some other papers assume that risk may be because men who have vasectomies may actually go and see the doctor more often and find the cancer more earlier than those who don't. Next slide, please. Now you got to know where the prostate's at. The prostate's basically localized at the base of the bladder. If you use your palm as the prostate, holding a balloon in your hand, that's kind of like how the bladder sits on top of the prostate. When you urinate, the urine goes through from the bladder through the prostate and out to the urethra. Next slide, please. The prostate itself is interesting because, again, most of the bulk of the prostate's in the posterior part that touches the rectum. That's why when they do a digital rectal exam, they could feel the prostate and they feel bumps. That's the biggest part of prostate. And therefore, if you see, the peripheral zone has 75% in the peripheral zone, central zone in the back so the majority of the prostate cancer are found in the back. However, sometimes we'll see high PSA levels, and the biopsies that are done from behind don't really give us the information because the prostate cancer may actually be in the anterior part of the prostate. So what do we have to do when we're doing biopsies? The next incidence is basically how to biopsy. The biopsy basically is the needle is put in through the perineum and the biopsy is taken. I'll show you that in the future. Let's go to the next slide, please. Now, prostate cancer is broken up into 4 groups. Stages, we call them, stage 1 through 4. Stage 1, the earliest stage. Stage 2, the middle stage. Stage 3, a little more advanced middle. And then stage 4 is the advanced, where it may go to the bones or other organs or the lymph nodes. Most of prostate cancer in the United States is found in stage 1 and stage 2. Smaller amount in stage 3, and that's usually incidental when they're doing surgery. They think the patient's stage 2, but then they found that the cancer actually goes into another area of the body, which is the seminal vesicles, or somewhere outside the body, or it's left behind. So it's a stage 3. So stage 3 are not actually that very often seen, but whereas stage 1 and stage 2 is most commonly seen. Stage 4, again, usually is presented with people who come with a backache, and they look at the bones. The bones have all these lesions in it. They biopsy the prostate. The prostate is actually the one that they know is bony lesions. But again, most of the stages we see are early stage. Why? Because we recommend prostate screening. Get your PSA done and get your finger wave, and then you get a chance of very high cure rates. And you can see here, based upon the stage, the cure rates are also commensurate at 5 years with that. We'll see that in the future. And staging actually goes into 3 things: T, N, and M. T meaning the tumor type, N is the number of nodes, and M is metastasizes. And that's the T and M staging. Next slide, please. Now, in the old days, you'd have surgery and they take your prostate out, radical prostatectomy. That was good, but it left you impotent. So very early on, in I'd say the late 60s, early 70s, they started giving cobalt radiation, or actually radiation seeds. A lot of seeds, radium seeds or things like that. But then over time, a newer technology emerged where they had linear accelerators, where instead of having cobalt radiation, which gave a lot of side effects, these linear accelerators had a deeper penetrating beam. Pre-2000, they had a two-dimensional picture. So basically, up front and side, you get the radiation and you'd be treated. However, after 2000, a three-dimensional picture was able to be demonstrated, and that came actually with the development of the Raptor computer, incidentally. If you all saw the Jurassic Park in the 90s, that was the first time they used three-dimensional imaging in one of the films. And someone was bright enough to say, hey, if we could do that, why don't we do that in radiology? So they actually used that technology. They became actually able to then generate a 3D picture from the 2D X-ray pictures they were able to take. So that became the dawn the dawn of more 3D dimensional treatment and targeting. And then after 2004, the newer technology, not only 3D, but also the ability to modulate the beam so we can actually form the beam around the area that we want to treat in the prostate, but miss the other part of the body was available. And also, along with the external beam radiation, we have implant, little seeds that you can put in. Some are permanent implants, such as palladium or iridium. Those you go in and leave the seeds. I'll show you that in the future. And the other ones are high-dose radiation seeds, where basically little needles are put in, they're connected to a machine. The machine brings a really high-dose piece of beam of little seed of radiation. It stays for a few minutes, and goes back into the box, and everything's removed. We'll show those in a minute. Next slide, please. So this is a demonstration of 2D radiation. Basically, you did a treatment. You tried to put a square box over an organ that's not square, and you tried to block out the best you could the rectum and bladder. And you can see in the middle the B, a lot of the prostate was treated, but then all the rectum and bladder also unfortunately got treatment too. So you had a lot of side effects. Cystitis, which is inflammation of the bladder, or proctitis, inflammation of the rectum with persistent bleeding. You were cured, but you had more incidents. So someone said, this is great, but it's not good enough. So then the next development was 3D radiation, as we talked about before. Next slide, please. So 3D radiation basically takes those beams, and we're able then to, in a 3D, using a CT scan versus just a little film, we're able to take the patient's actual anatomy, that's a patient there, measure the distance between the skin and down where we want to treat. The little white thing below that red is a rectal marker. You can see on the lateral part of the lower left corner, there's a little white thing in the rectum. That outlines the rectum, and that touches the prostate. And then the bladder is in front of that, and the third picture on the bottom right. So basically, we're using 3 dimensions now to treat the prostate. Therefore, we're able to avoid more rectal tissue, less side effects, avoid bladder, less side effects, and actually increase the dose to the prostate. We know from several studies that the higher the dose you get to a tumor, the less chance of it growing. And if you give high dose to the tumor and low dose to the surrounding tissue, that's the combination we want. In the past, because we didn't have the technology, we gave high dose to the tumor and high dose to everything else, and everything got really kind of messed up. And people then had the more sequelae or side effects. After 3D radiation, which we thought is great and still is good, let's still practice in a lot of parts of the world, we developed a thing called, let's go to the next slide. So just comparing 2D and 3D radiation, 2D radiation was limited because, again, the more the radiation you got, the higher the side effects. Versus 3D radiation, you get more dose and less side effects. Next slide, please. So IMRT radiation came with the dawn of a new machine. So just to let you know, radiation machines, the principle of the radiation machine hasn't changed since the 1950s when they actually made it. You basically have a machine that, an electron is, it's like a light switch. You turn the switch on, electrons that are coming from the electric company are pumped into the machine, and they're accelerated. That means they're increased by a long tube called a linear accelerator tube, and then they smash into a target and produce photons. The photons come out the head of the machine, and the machine rotates around the patient while they're on the flat table. Those little things on the side and the egg at the bottom is actually X-ray units that we can actually see that the patient set up correctly. So this is a modern radiation machine. So IMRT now, next slide please. IMRT now, instead of giving a few beams, we can do 20 beams, 30 beams, multiple beams all these little beamlets actually go and treat the area of the prostate, but again, avoids all the other tissues. Next slide, please. Again, these beamlets all go together, but they actually go to one area. Next slide, please. And basically target the area you want to treat, which is the prostate. Next slide, please. Now, after the external beam radiation therapy, there's another way to treat a patient. One is actually give some radiation to the outside, so we kill the prostate cancer and then the cancer in the lymph nodes. And then we do a thing called brachytherapy. Brachytherapy means close treatment. Brachytherapy basically is where you put seeds directly into the prostate and either they're permanent or you remove them. Next slide, please. So how does that work? Just like the biopsy, basically the patient's in a lithotomy position, that means the knees up, and an ultrasound is put into the rectum so you can see the prostate, and seeds then are directly deposited into the prostate. Next slide, please. Each seeds are put in there and then they're withdrawn, and little radiation seeds, pellets are left behind. These are the permanent implants, gold seed, iridium seeds and iodine seeds. So those you put in, they stay there forever, and basically give radiation to the prostate, but the rest of the radiation is not, you don't have other radiation, just those seeds as a boost. Next slide, please. This is kind of, again, the pictures showing the ultrasound. Next slide, please. And then next slide, please. And then the needle insertion on the bottom. We see the tip of the needle actually growing and drop the seed. Next slide, please. So there's basically the patient's perineum or bottom is where you put the seeds in, and then you watch like a tic-tac-toe, and you put them in there. Next slide, please. This is basically how we treat the patient. So the patients are in the lithotomy position. That's positioned on the bottom. Next slide, please. And the little seeds are put in there, and those are dropped in one at a time. And next slide, please. And a whole bunch are put in. Next slide, please. In the meantime, and as I'm dropping them in, I'm looking at the screen to see where the placement is. And then the other screen shows me as the seeds are dropped in, they're showing the radiation cloud around the prostate. Next slide, please. Again, more of the same. Next slide, please. And there basically is a prostate with the little seeds inside, demonstrating that the seeds are perfectly placed. Next slide, please. Now, instead of dropping seeds in and leaving the patient radioactive and walking around with the seeds, which basically they can do the same day, there's another way to do that. You put the little needle and hollow needles in, but use this machine. It's called a high-dose radiation machine. You put a lot of channels in, you put the seeds in, and this connects to the patient. The seed comes out of there, goes in each unit, and goes back in the machine. It takes about 15 minutes to treat the patient. And then you pull all the needles out, and the patient goes home with nothing in their prostate. Next slide, please. This is a demonstration, basically, of the needles put in, and then the high-dose radiation seed goes in, and it creates a little cloud, that red thing on the corner. That's a cloud of radiation, calculation radiation. Next slide, please. And basically, this again, basically, all those needles in there produce that red cloud. That red cloud actually engulfs the prostate and the cancer, and that dose basically treats the prostate like you give, instead of radiation from outside, you're giving from inside out. So basically, less side effects. Next slide, please. Next slide, please. And this again shows the placement of the needles. And when the radiation goes in, those circles, the red circles in the middle and the big blue circle shows the field of radiation. So you're treating the prostate and avoiding other organs that are near it. Next slide, please. So other than radiation, which again, external beam radiation, you have prostate implants that are permanent, prostate implants that are temporary. Next slide, please. During the patient, depending on their Gleason score and the PSA, we want to add additional treatment. So there are some studies that showing giving additional treatment, such as hormone blocking agents, Lupron or other medications, or Casodex, which is glutamide, also help reduce the size of the prostate and brings the PSA down. Some older studies show that showed about 215 to 20 patients. They showed that by giving 2 years of this medication, people live longer and have less prostate recurrence. However, that was based on 200 people. The current theory is if you're hypertensive or have cardiovascular disease, people who had long-term use of this had higher incidence of cardiac problems. So now we ask if people have hypertension or diabetes or some other cardiovascular issues, we'll keep them on this medication about 6 months, beginning before the radiation starts and finishing 3 months after radiation finishes. And then we take them off. This gives enough time for the function to actually reduce the size of the prostate, bring the PSA down, and we get the same benefit. Now, in longer term, in more advanced disease, These agents are, for instance, if you have stage 4 prostate cancer, you most likely will have these medicines starting with, and then you'll give radiation to sites of the bone if you need it, or if there's the cancer of the prostate doesn't shrink, you'll give the radiation to the prostate for help to shrink it. But again, it's a stage 4 patient, the cancer is all over the bones. These actually produces great long-term palliation or increase in the patient's life. The new agents now, the anti-androgen agents are now actually became gene targeted. Before you had basically hormone blocking agents like Lupron and Casodex, and then you'd have to go to chemotherapy, like you see Paxlovid and carboplatin or other medications, and taxanes being the most sensitive for prostate cancer. But now, the chemotherapy is actually pushed even further down with these new drugs. There's multiple new gene-targeted therapies that are basically super hormone blocking agents that we use either alone or with Lupron and or with steroids. And an example is, I had a patient who was treated, he was a 55-year-old gentleman. He went into remission for about 5 or 7 years, and he had increasing PSA. We did studies showing a recurrence. We then treated him with and his PSA kept rising. We treated with Lupron. He got several years of good results with Lupron, and then he started to fail again. So then we had to add something else. We put in gene target therapy for the last 4 or 5 years. He's been actually, basically PSA is less than 0. So again, these other agents, which are targeted agents, are actually very beneficial to prostate cancer patients. Next slide, please. So what's the good news? The good news is, if you're localized prostate cancer, stage 1, stage 2, or stage 3, your 5-year survival is 100%. This is metastasis stage 4 disease. This is from SEER data. This is a study. Their survival rate is 31% in 5 years. We have data we're about to publish where our stage 1, stage 2 patients actually do live 100% with no recurrence. Not at 5 years. We actually have 10-year data and 15-year data, but definitely our 10-year data, everyone's alive and disease-free at 10 years. Our stage 3 patients, we have also, we don't have enough stage 3 because again, they're not that many, so we can't make a decision, this 10-year statement, but all our stage 3 patients for 5 years have 100% survival rates. Our stage 4 patients actually live very, very long. We have patients who are 10 or 15 or 20 years out who have stage 4 disease. So, well, this is the 5-year average of all these hundreds of patients, thousands of patients, I should say, in our institution. We have very good results of even stage 4 patients living a decade, if not 2 decades. So the good news is, get your PSA, get your rectal exam, and if you do have cancer, the treatment is easy to take, and the good news is you'll live a long time. With that, I open it to questions.
Okay, stop the share.
Thank you. That was excellent, excellent. Dr. Climie, do we have some questions?
Let me see here. I was not able to see while we were doing that. Let me see here. We don't have anything in the chat room yet.
So let's say, how would people know if they have prostate cancer? Well, really, you don't. You really don't know. You don't have an ache. You don't have a pain. It doesn't say, hey, my prostate's hurting. That's an organ that really doesn't have much incidence. Now, sometimes you'll have urination, and you'll have blood in the urine, or you might have, let's say, a bone ache. So blood in the urine is something the urologist will check out and may find that you have the prostate cancer. Or if you have bony ache, that may indicate that you have advanced disease. Where again, a lot of our patients come in, they're very healthy, they're just not very apt to follow up with doctors, and they haven't seen a doctor for 25 or 30 years, and they say, my back aches. They take a pain x-ray, and there's a big mass there, and that's from the prostate. Prostate metastasized to the bone. So basically, this is kind of a quiet disease that you really don't want to wait until it knocks on your door. You want to get in before it knocks on your door.
All right.
So how early do you recommend that they get the rectal exam and the prostate exam done besides the PSA?
So if you have no family history of prostate cancer, starting age 50, PSA and rectal exam every year. Okay.
Age 50. Does it stop at any age?
Well, there are some people who say, after 80 or 90 or whatever, but I'd have people who are 90 whose parents lived to 100 and they want a treatment. So
They had
you
good
know,
genes.
it's so we've treated people from the 40s to the hundreds because again they're folks don't want the disease to spread to the bone, and so if it's earlier or even more advanced in prostate, we can address it.
What about the symptoms of either waking up at night, having frequent urination nocturnally, or the symptom of not completely emptying your bladder or having to go back? Are those
That's also very
suggestive?
that is indicative. Yeah, that is indicative that your prostate may be enlarged and you're not emptying the bladder. So it's usually it's a benign prostatic hypertrophy, which is BPH in most of the cases. However, that may indicate the prostate's big or the tumor. There's a tumor there blocking your urethra or emptying your bladder, and so again, that's how it's detected.
We have some more questions coming up in the chat.
Okay. We have one here that says, I'm 56 years. What would be a good way to prevent it?
Okay, so very good. So other than rearranging your genes, not too much, but some people think diet, low fat diet, lycopene, which you see in tomato sauce, tomatoes, lycopene, and also the residue is in the red wine or the grape juice. Grape juice may be anti-inflammatory. Zinc, they believe, may help a little bit. There was some studies seeing that people who if they use vitamin E, that would decrease the prostate risk. Those studies didn't show that high vitamin D usage decreased prostate risk.
Okay. We have another question, and it said, should I have any concern when one testicles hurt or feel tender?
If it comes and goes away, it's not a problem. If it's persistent, you should get it checked out because that may indicate you have a testicular problem or testicular cancer. So the male genital urinary system basically starts at the kidneys, goes down the ureters, the bladder, and underneath the bladder is the prostate, and then the testicles. So all that area is basically when you're formed in the womb. That comes from certain tissue, particular germ tissue, and so it's not uncommon for people who have prostate cancer to develop kidney cancer, and vice versa. If you have kidney cancer, you may have prostate cancer or bladder cancer, because again, that comes all from the same basically morphological or primitive endocrine cells.
All right, thank you. And we have another question here. Are there vitamins or a certain diet that would prevent prostate cancer?
Well, prevention is always important. Exercise and diet, they always recommend. Diet, again, as I mentioned, certain food products, lycopene, actually been shown to help. Zinc products. If your prostate is enlarged, there is a over-the-counter vitamin, and it escapes me now for some reason, but it actually helps shrink your prostate without a prescription. And if you do have this problem, enlarged prostate, your doctor can give you another medicine that's a prescription medicine that you take every night, and it shrinks your prostate and help you urinate. So by doing that, also by shrinking your prostate, is also bringing down your PSA. So it actually suppresses the hormone stimulation of your prostate, and that actually shrinks your prostate. And so that's just like the hormone blocking agents, the higher dose ones, where we give the hormone blocking agent that basically, if this is the cancer, and you need the cancer, this is the cancer cell, and the hormone comes in and turns it on, and the cancer grows. What happens is, this is the cancer, and the hormone blocking agent comes in and sticks in here. So when the cancer comes looking for it, they can't turn it on because there's a block in it. So then that way the cancer shrinks or dies because it's not stimulated by the hormone. So that's what basically how the hormone agents work. They're basically somebody stuck something in the keyhole so that the hormone can't stimulate the tumor, so the tumor shrinks, the prostate shrinks, and all the cancer actually shrinks in the body.
Okay, thank you. Then another question: as a supplement, do you recommend saw palmetto?
Yes, thank you. That's the yes, supplement saw palmetto will actually shrink your prostate. There's studies that show it's effective as almost it's not as strong as the prescription strength, but it will do the same thing that prescription strength medicine will do. It will shrink your prostate and actually help your prostate syndrome. Saw palmetto, that's great.
All right. Then another question here: what type of food should be avoided that could cause prostate cancer?
Well, just like in breast cancer, obesity, the fat actually holds your hormones. So the estrogens are trapped in the fat and that they think that helps overstimulate the breast tissue and produce breast cancer. Same thing in men. If you're overweight, the fat actually may hold some of these steroids or the hormones that may stimulate the prostate cancer. So foods lower in fat, leaner meats, vegetables, and again, certain fruits and vegetables with the tomato, lycopene, and the other type of zinc or selenium-based foods may also decrease that risk.
All right. Okay. So there isn't anything. This is my question now. So there isn't anything that you're going to eat that is going to directly cause you to have prostate cancer, but if I have a generally bad diet, then the fact that I am putting on this additional fat is going to give me a propensity to have cancer.
Yes, again, that's the studies basically show that. And again, we see that in the incidence of both prostate cancer and breast cancer in the Asian population. So the first generation Japanese women, for instance, come in and they have their breast cancer risk are very low, as is our men. Second generation increases, but the next generation increases. By the third generation, it's as if they were just born here in the U.S. because again they lose that protective ability, and we think it's related to diet, the higher incidence of fish or vegetables or different things in their diet.
Okay, all right. Let me see here. Here's another question. Is the PSA and an enlarged prostate, okay, are the PSA a chemical telltale and the enlarged prostate an anatomical telltale the only indicators of prostate disease?
That's a great question. So in the past, we had PSA, which is prostate-specific antigen. This antigen is directly specific to that gland. Just like we have specific antigens for breast cancer, pancreatic cancer, and ovarian cancer. They're specific for the organ. They're not elevated in any other organ except that. So that antigen. And that antigen is very interesting. That was actually when they found that antigen, they to get our PSA level that we use as normal, though that actually information came from military. The young military recruits between age of 18 and maybe 30 or 40. So our 0 to 4 PSA that we use as normal was actually the information was obtained from that younger population. So interesting enough, as you get older, your PSA increases naturally. So when you look at the older folks who have higher PSA, some of that may be benign from the prostate just getting big, because again, that initial information was based upon younger men's prostate data. So what we do is we look at the PSA, but we also look at if the PSA is rising over time. So we look at time to rise. And the second thing we now can have, which we didn't in the past, was a new PSA, which is the targeted PSA, which is called free PSA. It's not free because it costs money to get it, but this is like a general PSA, but this free PSA is specific for the prostate. So let's say your prostate is enlarged, the PSA goes up, not because, or you have a urinary tract infection, prostate or prostatitis, your PSA will increase because the inflammation produces the release of this enzyme in your system. But the free PSA will differentiate from benign to malignant, because if the free PSA is low and the regular PSA is high, it means high and low inverse, that means you have prostate cancer. If the free PSA is high and the PSA is high, you have inflammation. So it's actually directly inverse related. Higher PSA, lower free PSA means you have prostate cancer, whereas if both are elevated, that means an inflammation. Now that's great, because now we can differentiate benign prostate problems from more malignant. So if you have a high risk of having prostate cancer in your family, I ordered both the PSA and free PSA in the patient, so I can see if that actually is there. A third now let's say that happens, and now you want to biopsy the patient. The patient's like, well, I really want that needle, and it's pretty ouchy. There's a new PSA determined that came out. It's PC3A. So it's a super PSA, basically. It's a gene targeted PSA now that basically I use as a tie buster. So I have a patient who we see this PSA inversion PSA, and it's rising 2 or 3 times, and we want to know if this is really it, or the PC3A, and that will say positive or negative. If it's positive, it says you have a high risk of having prostate cancer. And if it's negative, it says it's not prostate cancer. So statistically, if you biopsy those patients, most likely to be negative. I had a patient, just again as a example, elderly gentleman whose PSA was just, it's like PSA of 3, 3.3, 3. And then inverse, so it's kind of borderline. And it was rising, so I said, well, he's elderly, let me just do this PC3A. It said it was positive. So he went in for biopsy, and they did the usual 12 cuts, 12 needle placements. In one of the 12, at the tip, they found it. So that's how sensitive it was. So that was very interesting, because a lot of times, just like a needle in a haystack, when the doctor goes in, he's kind of poking in the dark and hopefully get something in the area. And that, as I showed you, the 2/3 of it is posteriorly, 1/3 in the front. You get a shot at because of the way they biopsy. So that actually tells us that it's a higher probability.
Oh, okay, excellent. Yeah, speaking as a man who hasn't had a PSA or a exam for probably 7 or 8 years, it's
Oh no.
yeah, I know, it's probably time for me to get in there. All right, we
Yes,
have okay, okay. So we have someone who didn't quite catch it, the new PSA test. Just very quickly, could you highlight on that again, how the new PSA test works?
Yeah, so the old PSA basically is basically looking at the enzymes that the prostate produces. The new PSA looks at the gene, the cancer gene that prostate produces. So it's gene specific to the prostate and the prostate cancer, actually.
All right. So the old one is actually looking at the PSA
enzyme released by the prostate.
Right, by the prostate. And this one here is actually looking for the gene itself. How
gene.
interesting. Okay, another question. Is urinating for a long period of time a sign or symptom to prompt any concerns?
Urinating, let's say it takes a long time to get your urine out. That's what I'm saying, a long period of time.
Right. It's not saying whether it is a weak stream or a strong stream.
Right.
Simply you're urinating for a long period of time. Should that prompt any concerns?
Well, if it's a normal or forceful stream, that means you have a good capacity and a long capacity. Maybe you should be a big runner. But if it's a very slow stream, it takes a long time. That may indicate your prostate's a little bit bigger and it's decreasing the caliber of where the urine can come out. So it's taking a longer time to empty out versus the normal open. It would be a little smaller. So it's going to take a longer time to go through that same area. And that's something you should go get checked out.
Okay.
And how do you do that? Well, basically they do ultrasound, a rectal ultrasound. They can do an MRI of the prostate, or they can do a CT scan. All those 3 modalities actually show us the size of prostate.
Okay. Let me see here. Does there's a drug that is prescribed called Flomax. Is the use of Flomax going to affect the ability to detect prostate cancer?
Actually, Flomax was developed as an antihypertensive medication. Basically, what it does, it goes in and relaxes the muscle of your urethra, just like it relaxes the muscles in your arteries to open things up and let it open. So basically, what it does, it goes and opens it up so it's easier to empty your bladder, because the muscle is not so tight. Flomax makes it kind of open up a little bit easier, so you can empty your bladder more fully. Instead of having a little tight opening, it opens it up so it can empty quicker.
Okay.
So Flomax will not introduce any adverse effect to your prostate or cancer itself.
All right. So that's not going to, if your weak urine flow is your initial indicator that something is wrong, your prostate's enlarged, and you talk to your doctor, and the doctor says, "Oh, here, use this. This is Flomax that will open things up and let it go, let you go more completely or with less of a strain." But that is not going to affect your PSA or anything else.
No.
So you're not going to be able. It's not going to inhibit the doctor's ability to detect prostate cancer if you're using a drug like Flomax. Correct?
That's correct.
Okay, good.
That's correct.
Okay. Let me see here. I'm
There's
not getting any more
another
questions. Dr.
question
Satya,
here.
do you have something?
Yes. There's another one. Do you want to take that?
Oh, okay.
Sure.
Here we go. If symptoms appear, what is your recommendation or where to start for a doctor's advice?
Okay. You can go to your family doctor, and you can ask him to run do a wellness exam. Wellness exam includes the PSA, and you can request free PSA, because a lot of family doctors won't do both. Just request a free PSA with the PSA, and then they do a digital exam of the rectum and see if there's any bumps on the prostate. So just to kind of give everybody kind of an idea what the normal prostate feels like in your body, if you touch your nose, it's that soft part right here. That's what the prostate feels like. Now, if you have a tumor, you touch the back of your hand, and the nodule feel like this inside the prostate. That's tumor on the prostate. So this is the normal feeling, but the tumor feels more like a knuckle.
Okay. All right. Excellent. Thank you. Okay. There's no more questions on the chat. Dr. Satya, did you have a question?
There's one more. Yeah. In terms of treatment, with hormone treatment, how often is there enlargement of the breasts as a result of treating the prostate as a side effect? And what drug produces that, and who gets that side effect?
So what I do is, if this is a patient who's coming in for curative treatment, they'll get a Casodex initially. That helps to decrease the flare of the PSA, and then they'll get the Lupron for 6 months. Let's say 6 months. Then they're done. By that time, they'll have hot flashes and some sequelae, but the breasts don't usually get enlarged. They may get a little tender, but they don't get enlarged. With patients who have more rising PSA, or if they have recurrence and they're on this long term, in about 1 or 2 years, I start them with a little pill, the Casodex pill, before I graduate back to the Lupron. Usually within a year or so, the breast will enlarge and they'll get a little tender. Adding Lupron to that, again, the breast will enlarge and get tender. If folks who have men who get enlarged breasts or get tender, we treat them with a very low dose of radiation to the breast to stop the tissue from growing. So basically, we give a few treatments to the breast, and that suspends the breast tissue from growing under the hormone treatment.
Okay.
So yeah, they will grow with the hormone ablation, because again, basically they're blocking all the male hormone. And in our bodies, both men and women have testosterone and estrogen. So if you block the testosterone, there's estrogen flowing in men's body. The estrogen has an estrogenic effect on the breast. The breast is enlarged. Same thing with women who have androgen or blocking agents against the breast, their testosterone increase a little bit, and basically then they have the changes also with that.
All
So
right.
it does not mean that the man is having possibly breast cancer as a result. And
No,
is
no.
that, yes.
Breast,
So
breast cancer is very, very rare in men. If you look
In
at
men.
the incidence of breast cancer overall, 99% of women get breast cancer, 1% of men get breast cancer. And
Correct.
again, that 1%.
So just enlarged
very-
breasts does not mean
Yes.
that you have breast cancer.
No,
And
it
then,
means
of
that the
course-
tissue are stimulated. Yeah, it's stimulated because again,
Yes.
it's fatty tissue that's getting stimulated.
Correct.
Okay. And then when you say that you experience some enlargement of the breast tissue in the males, it's are we talking a a noticeable change, or is this something that only the guy himself would feel? Wow, that's a little tender, and maybe my breasts are getting a little large here.
It's in degrees. Some are minimal, some are significant. So yeah, I mean, even up to a B cup I've seen.
Okay, so but you are
Yes.
able to actually fight that reaction by using radiation.
Yes, the radiation again, a few doses of radiation to
breast.
each breast suppresses
Yes.
the breast from growing, and then basically we're able to continue.
Yeah, I had someone whose husband was diagnosed with having the prostate cancer, and without the doctor explaining to this woman what would be involved, all she had heard about was the hormone therapy, and her first response was, "Well, I don't want my husband turning into a woman." And it so affected him that he refused to get any type of treatment, and ultimately died from it. And
No.
yeah, so it was really an unfortunate thing.
That is
So
sad.
if I just wanted to go over that for anyone that's listening out there, if there is an enlargement of the male breast, then don't keep it a secret. Talk to your doctor about it, and they can take some steps to normalize the breast.
Correct.
Okay.
Correct. And yes, and there are also other medications you give along with that
To minimize it.
decrease this in the breast too. So you can have
Right.
oral medications with that or the radiation.
All right. We have another question. Is ED a sign of prostate issues?
It depends. ED is actually associated as you get older. Your testosterone drops. If
You want to expand what ED is, please?
Yeah. Erectile dysfunction. We can't get erection for intercourse. So a lot of times ED is associated with age because of the drop in testosterone, but also if you have hypertension or diabetes. If you're hypertension, use hypertensive medication. That medication will decrease your ability to have an erection because again, the erection is based upon the blood flow to the penis. The medication basically dilates your vessels, so the blood flow is not able to have a significant flow to the penis, and the penis doesn't get firm. So hypertension, diabetes, and low testosterone or low androgen levels are the usual cause of erectile dysfunction, which is a normal kind of progression in age also.
Okay. So.
And not related to cancer at all.
Unrelated to cancer.
Yeah.
All right.
Now, after cancer, that's a good question too. Because after cancer, can you have sex, and are you potent? So that's very interesting. So during again even the radiation for patients here, if they're on the hormone blocking agents, again that suppresses their hormones, so they're having a harder time getting erections. For that, they can use medications that will actually help them get erections, as seen on TV, the blue pill and other things. After radiation is over also, there's statistically a drop in their testosterone if they've had hormone blocking agents, even years after. So the 6 months or so from your hormone shots will actually leave them with a lower testosterone level throughout their life. Now, it's good in some sense that the lower testosterone level will not stimulate their testicles or the prostate cancer in their body if there's any left. So it's a lower chance of them developing or redeveloping the prostate cancer because it's a lower level, so it's less level to stimulate. But on the flip side is now they're going to have problems with achieving erections because again the hormones are less. And also, they have a higher risk of osteoporosis because both estrogen and testosterone are androgenic. Androgenic means muscle building, red blood cell building, and bone building. So now you're decreasing your androgenic effect. So there are studies that show people who have had prostate cancer or are on hormones, supplementation of therapy for long term. The recommendation is physical exercise, weightlifting, and moving around, because by pushing the weights and making your muscle move, it's kind of androgenic. You basically induce androgenic effect by making your muscles produce tension on the bones have become stronger, and so basically you prevent osteoporosis and the secondary effect of hormone ablation. And again, impotence, again, if you have radiation. Now there's with surgery, impotence is fairly high because they have to cut the nerves to the penis to get the prostate out, to do radical prostatectomy. They have a thing called nerve-sparing prostatectomy, but when they spare the nerve, they also leave some tissue on there, and that may be also cancer-sparing. So when they can achieve erections after the nerve-sparing prostatectomy, you have a higher incidence of also leaving some tissue from the prostate, which may occur when you have recurrence of your prostate cancer. So what we do is we know that statistically, men who have radiation maintain their erection about 60 to 80% of the time. With that being said, it seems like that's not very much, but our average age of patients having radiation to the prostate or prostate cancer are the mid-60s to 70s, the average age. So you have the 40s to 50s and the 90s to 100s, and their average age is somewhere in between. So in older 60s or early 70s, that's our average age of prostate cancer. So when you look at the normal physiological abilities of a man in his late 60s or early 70s, it's going to be less than a man in his 30s or 40s. So the potency level is going to be affected naturally before the cancer is treated.
Okay. All right. Let me see here. We're not receiving any more questions.
Just
Dr.
another.
Tapia, back to you.
Yes. How about if you can address a little bit more on effects? I mean, your talk was excellent of how you've improved so much in terms of how focused you can provide the radiation and or how you're doing the biopsies and all of that in terms of the treatment. But given the anatomy, perhaps can you explain a little bit on radiation effects, perhaps colitis related,
Sure.
Given the proximity of the prostate and the rectum,
Sure.
and what that might look like, what to expect, and what they need to do for that?
Sure. So if you want to put that picture back again.
Here we go.
Perfect.
You did it.
So perfect. So you see the bladder is basically on top of the prostate. Again, if you think your prostate's your palm of your hands, the fingers are semical vessels you see behind there. Some of those are your fingers, and you're holding a balloon in your hand or a softball. So to do a prostate examination, the doctor puts his finger up your bottom, and he can feel your prostate. So your prostate actually is touching your rectum. So and you see how the bladder lays on top of the prostate, because again, the bladder flows, the urine flows through the bladder and the prostate down your urethra and out. So basically, when you treat patients with prostate cancer, you have to nip a little bit of the rectum and a little bit of the bladder. So let's go to slide number 7.
7?
Yes.
Okay. Go to slide number 7.
So just at this picture, you can see how where the rectum is.
Yeah.
And then where they're introducing the finger, your primary care, and then they can palpate the prostate, which he described how it should feel like the tip of your nose.
Go one more down if you wouldn't mind, the next one down.
Okay.
Okay, so this is a composite of a prostate. So the red is the prostate. So you see here, we're able to cover the prostate, and this is a bigger field. The rectum itself is getting some radiation in this picture, but the newer treatment fields can go up and form around the prostate, missing the rectum, and then also misses a lot of the bones in the pelvis, and also the bladder. The bladder, if you go down to, you see the corner there on the left corner, you see
the rectum is that white area with the black spot.
Yeah, black spot. That's a little tube inside the rectum, but the rectum actually goes to the bottom of the red thing. So this is again 3D radiation, but the IMRT actually goes and just all you see is treated as the red area, and the other areas we want to treat for the lymph nodes, let's say in the right lower corner. And that bladder actually is outside our field. And another thing we do to kind of to surprise or fool the radiation beam is we have, when that little white tube is in there, we actually have now a balloon that we inflate, and it pushes the prostate up and the rectum back. So you don't actually treat the prostate. The rectum is pushed out of the field by the balloon that the patients get when they go in. And then we ask them to fill their bladder up. When the bladder is filled up, it pushes the intestine away. And so we're able actually to treat just the lower part of the bladder and the rectum. So we actually have much less side effects with the IMRT radiation than we do with 3D radiation.
All right.
Excellent. And this 3D radiation is really beautiful. I mean,
yeah, well, this is we used that until the early 2000s. Now we consider this primitive. I mean, but it does the job, and less side effects. There's even less side effects with IMRT radiation. Now, there's also things you might hear. Think this is photon radiation. There's a thing called proton radiation, which are heavy particles, and they're getting some play that say they can treat and give less side effects. Well, not really, because the photon radiation, I can take it, I can bend the radiation beam around anything I don't want to treat, but miss everything else. The proton radiation is like this. It travels in a straight line, so you can't really bend it. So really there's a higher rectal dose and bladder dose. Even though theoretically it treats less tissue, it's not flexible, so you're actually treating more higher doses of the rectum and bladder than you can with photon radiation. This is the actual IMRT radiation.
Okay.
Yeah, this is the machine, and then go down one more. And there's the multiple beams. Instead of the 4 beams you saw front, back, side to side, we have anywhere from 6 to I've seen 28 beams. All these little beamlets, some are blocked. So all you do is you get just a very conformal treatment, and all the tumor is treated, but the area of the rectum and bladder and the heads of the femurs are protected. So instead of the 2 beams or 4 beams or 6 beams, we could do 20, 30, 40 beams, and then we do 3-dimensional beams. Something comes up through the pelvis, so it's 3-dimensional treatment versus 2-dimensional treatment. So this is much more advanced, less side effects, and patients tolerate. A lot of folks will come, get the treatment, go to work, and go play golf, or on the way home from work they'll stop, and there are very, very minimal side effects.
Thank you. That was excellent, excellent. I think I don't know what time it is, but I think we're about 8:01. So that's perfect timing.
Okay, so the question is this painful? No, radiation is like taking an X-ray picture. You'll feel absolutely nothing.
No pain.
The treatment lasts about 8 to 9 weeks because, again, with these newer radiation beams, we're able to push that dose really high into the prostate, and that takes a little more time than in the past. So we're able to treat these folks. You'll feel absolutely no pain. In about 1 to 2 months, you'll notice you'll pee more frequently. So you have to more frequent urination. And toward the last week or two, it may have a little burning when you start start your urination, or when you stop, a little like burning sensation. But all that goes over 1 to 2 weeks after radiation is over with. So there's really no pain, nothing else. And very rarely do you have a thing called proctitis, which is inflammation of the rectum, or cystitis, inflammation of the bladder. We have blood in the urine or blood in the rectum. If you do, usually it heals itself within 90 days or 120 days after radiation is over.
Thank you, Dr. D'Andrea. That was awesome. Those questions, folks, were really good. Very, very good, very informative answers and solutions. I think that will allay any fear that, a lay person might have. So I want to thank you, Dr. D'Andrea, despite your busy schedule. You came along.
If folks want any information, we have a website, universitycancercenters.com, www.universitycancercenters.com. Call our office. We're happy to talk to you. We have also a website and have information on the website. Again, if you have any questions or want some information or come for screening, we're happy to help you.
Thanks.